Well, welcome. Welcome to National Harbor and Hospital Medicine 2019. I'm Dustin Smith, course director for this meeting and an Emory hospitalist at the Atlanta VA. This marks the third time in the past 6 years SHM's annual meeting has been held here in National Harbor. Whether this is your first time attending hospital medicine in National Harbor or not, we are incredibly excited to welcome all the near 4,000 of you here for our comprehensive educational program. For the first time for this year's conference, SHM introduced a new open call for content for speaker and topic suggestions for both workshops and main conference didactic sessions. We received a ton of great ideas and session proposals from many of you. By trusting the process for HM19, we feel confident your ideas allowed the annual conference committee as well as other SHM committees to craft a conference that's truly for hospitalists by hospitalists. Over the next 3 days, we have a wide array of didactic sessions offered that are housed in various tracks or districts. While some districts may offer more sessions than others, the guiding principle for track creation and session scheduling was always that all are created equal. I encourage you to attend sessions that meet your educational needs, but also challenge you to embrace diversity in topic areas for those things that may be out of your comfort zone. Download the HM19 at Hand app to help you plan ahead and easily navigate the conference, including accessing the schedule, checking in at sessions, rating speakers, and networking with other conference attendees. And while you're on your phone, share your thoughts and photos on Twitter using the hashtag HospMed19, which conveniently is the Wi-Fi password as well. While here, attempt the Bird Box Challenge and check out a workshop new or unknown to you, including those workshops receiving nominations for career development, like these individuals here who attended the Being Female in Hospital Medicine workshop at HM18, which by popular vote was re-elected for a second term here at HM19. New this year are educational tracks between the guidelines and clinical mastery. Consider attending these tracks to see where your practice expertise matches clinical practice guidelines and also those traits of a master clinician. This year, we increased the number of sessions in the Great Debate track. We're also proud to feature more sessions focused on clinical updates and workshop than in previous year's meetings. We've embedded an airway course into the program based on the direct feedback from many of you. HM19 sessions also have a special content focus on diversity and population health for those applicable sessions. Now, HM19 is chock full of can't-miss sessions, including the visionary plenary sessions, the always entertaining updating hospital medicine. We have a best of research and innovations in 2019, and a timely session devoted to emergency preparedness for hospitalists. Day 2 reruns 6 of our most popular sessions in case you missed them the first time around. And don't leave HM19 early. We've saved some of the best for last on Day 3 with Medical Jeopardy, 2 Stump the Professor sessions, and an update in medical education. Really, we expect all sessions here at HM19 to be can't miss. So take advantage of HM19 on demand. It's available at the registration desk for $199. That cost goes up after the conference. What it is, it contains more than 100 online audio and slide recordings from our most popular tracks and sessions here at the conference. And you can get CME credits and additional mock points off of that. More information can be found at shmannualconference.org/on-demand. A significant number of you attended the Academic Leadership Summit yesterday. Even if you didn't and academic hospital medicine is your thing, then you're in luck, as we have a dedicated track for this at HM19, in addition to a ton of great academic events embedded into our program, which you can see listed here, such as mentoring sessions, special interest groups, a research Shark Tank, the Research and Innovations poster competition tonight at 5:30 p.m., and then the clinical vignette poster competition tomorrow at high noon. Don't forget to visit the exhibit hall today at 11:35 a.m. for lunch and throughout the rest of the conference. During your break, stop by the product theaters in the exhibit hall for SHM quick talks and pop-up sessions, which are shorter, more provocative sessions on some of the hottest topics in hospital medicine. Special interest forums are held today and tomorrow at the conclusion of the main conference schedule. There are also other great bonus sessions daily at 5:30 and nightly satellite symposia for you to attend if you're still hankering for more education at the end of the day. See the inserts in your HM19 bag or the HM19 at Hand app for more details. Like what you see this year? Do you have recommendations for how to improve our conference? The call for HM20 speaker and content suggestions for both workshops and didactic sessions is already open. Help make HM20 great again by going to SHM's website to access the speaker and topic submission portal to share your ideas. Please act fast, though, as the deadline for submitting your ideas for HM20 closes April 5th, 2019. Now, you came for the education, now we ask you to stay for the movement. This year's proximity to the nation's capital allows for the conference to take place in conjunction with SHM's Hill Day on March 27. Come join fellow hospitalists on Capitol Hill in Washington, D.C. to have your voice heard with regards to political issues important to hospital medicine. At this time, I would like to ask the members of the Annual Conference Committee for HM19 to stand. It's been an honor and a privilege to work with such an innovative and dedicated team of individuals in curating HM19. I want to extend my sincerest thanks and appreciation to all these volunteers on the Conference Planning Committee, and especially want to thank SHM staff members Brittany Evans and Haley Lawrence. Please join me in giving them a well-deserved round of applause. With that said, we are always striving to make this meeting better and more timelier for you. So the Annual Conference Committee planning members will be wearing special ribbons on their badges to identify themselves. Please feel free to find us and give us any feedback you have. We hope that you thoroughly enjoy the program at HM19. Thank you for attending. All right, at this time I want to introduce Dr. Larry Wellickson, CEO of SHM, to the stage. Thank you.
Good morning, everyone. I want to welcome you to the HM 2019. This is my 20th annual meeting, and it never gets old. We're going to have close to 3,600 hospitalists here to enjoy the education and the networking. And I just wanted to take a brief moment to call out some things that have happened this year. And this year, we were one of thousands of organizations that applied to create a national day, and only 30 were selected. And we held our first National Hospitalist Day early in March, and we were really gratified with the national response, both locally at hundreds of hospitals and throughout social media, that we plan to continue this tradition in the first week of March every year. And if you want to get involved, you simply need to go to #HowWeHospitalist to see what we have planned. But I think it's an opportunity. A lot of hospitals really appreciated the opportunity to honor you and your colleagues for the strong work you do to make your hospital and your health communities better. And so, as I said, look for National Hospitalist Day, which will be on March 5th, 2020, and get involved, do things locally at your hospital, and post them on social media to share with the rest of the hospital medicine community. And with that, I'd like to introduce our current president, Naseem Afsar. She is the founder of the Los Angeles chapter. She has been chairperson of the Hospital Quality and Patient Safety Committee. She's been on the board for the last 6 years and is just completing her term as president. In addition, she is the chief ambulatory officer at the University of California at Irvine and the chief executive for their accountable care organization, and in her spare time, she's a mother of 2. So it's been my privilege to have worked this entire year with my good friend and colleague, Dr. Naseem Afsar.
Thank you, Larry. Good morning, hospitalists. Good morning. What a wonderful meeting, and I'm energized looking out here at all of you. What a great opportunity for us to learn, meet new people, and collaborate together to change healthcare for the better. So we've got an amazing 3 days planned for you, and I hope you take full advantage of that. We are going to need some leaders who are going to be able to move us forward, and it's with that that I would like to introduce the induction of our 2019 Fellows in Hospital Medicine, as well as Senior Fellows in Hospital Medicine. This is now the 11th class of Fellows and Senior Fellows. So today, nearly 250 hospitalists will be recognized as either FMs or Senior Fellows in Hospital Medicine, SFHM. They join a rank of more than 1,800 other SHM members who have made hospital medicine their career and have set themselves apart in our specialty through their commitment to patients and improving care. Fellows can take advantage of a number of special opportunities, including at this meeting, the Fellows Lounge, and please access those lounges throughout the meeting. At this time, I'd like to invite our new fellows and senior fellows to stand up and be recognized. I'd like to ask you to please remain standing. I would now like to ask all the current fellows and senior fellows to please join them and be recognized. Congratulations, everyone. The Masters in Hospital Medicine is a designation that was introduced in 2010. The MHM designation is reserved for hospitalists who have uniquely distinguished themselves in the specialty of hospital medicine through their excellence and significant contribution to our specialty and healthcare as a whole. Today, we will induct 2 new Masters in Hospital Medicine. They will join the other 28 Masters in Hospital Medicine from a universe of over 60,000 hospitalists nationwide. This is truly the Hall of Fame for hospital medicine and our society. I would like to ask Dr. Brian Hart to join me up here on stage. Dr. Brian Hart has been elected Master in Hospital Medicine in honor of his unwavering dedication to hospital medicine and Society of Hospital Medicine as a stellar clinician and an inspiring leader. After completing his internal medicine residency at UCSF, Brian started his career as a frontline hospitalist at Marin General Hospital in the Bay Area near San Francisco. He was then recruited by the Cleveland Clinic to join their growing hospital medicine group. Because of his expertise in improving hospital operations while continuing to uphold the highest standard of clinical care, Dr. Hart advanced quickly, developing and growing a presence of hospital medicine throughout the Cleveland Clinic networks. Dr. Hart is currently the president of Cleveland Clinic Akron General Hospital in the Southern region, after serving as the president of the Cleveland Clinic Hillcrest Hospital and the Cleveland Clinic South Point Hospital. In addition to his role as a hospital president, he is also an associate professor of medicine at Cleveland Clinic Lerner College of Medicine at Case Western Reserve University. At SHM, Dr. Hart served on the board of directors for 6 years, including his role as treasurer and president. He has served on a number of SHM committees, including the Annual Meeting Committee and Public Policy Committee. He has presented at multiple SHM national meetings on leadership, quality and safety, and hospital operations. He has also served as a deputy editor of the Journal of Hospital Medicine for the past 9 years and was instrumental in the development of Clinical Care Conundrum series in JHM. Dr. Hart has worked as a frontline hospitalist, a hospital medicine leader, and a hospital president. He's also an SHM committee member, deputy editor, board member, and SHM past president. The Society and our specialty has benefited tremendously from Dr. Hart's unwavering dedication. Please join me in congratulating Dr. Brian Hart for being named Masters in Hospital Medicine. Thank you. I would like to ask Dr. Samir Shah to join me up on stage. Congratulations, Samir. Dr. Samir Shah has been elected a Master in Hospital Medicine in honor of his leadership in hospital medicine as a stellar researcher, devoted mentor, and a key contributor to Society of Hospital Medicine. Dr. Shah is currently the Professor of Pediatrics at University of Cincinnati College of Medicine. He's also Director of the Division of Hospital Medicine and the Chief Metrics Officer at Cincinnati Children's Hospital Medical Center, where he holds the James M. Ewell Endowed Chair. Dr. Shah is also a leading figure in the founding and the growth of pediatric hospital medicine, assuring that robust research is the central focus of our evolving specialty. He has authored more than 300 peer-reviewed publications and 150 book chapters. His research has been supported by grants from numerous federal agencies and foundations. He has served as the primary research mentor for more than 85 medical students, residents, fellows, junior faculty, and postdoctoral students, and he has been a career and professional development mentor to countless others. He is the primary research mentor for 5 current NIH and AHRQ K-Series Career Development Award recipients. Dr. Shah has helped to develop a better leverage of data infrastructure to help scale research and link variations in clinical practice to outcomes nationally, to determine the best clinical practice for our patients. For example, he partnered with Dr. Matthew Hall of the Children's Hospital Association as an inaugural member of the Pediatric Health Information System Research Group in 2005 and became the chair of the group in 2007. While his individual research accomplishments are exceptional, his more lasting impact in pediatric hospital medicine has been creating and growing research networks and advancing academic growth of the field, further multiplying his efforts to expand our field. He received the 2009 Award of Excellence for Research from SHM and has served on the research committee. In 2019, Dr. Shah became the 3rd editor-in-chief of the Journal of Hospital Medicine, SHM's flagship peer review publication for hospital medicine. Dr. Shah has already done what seems like a lifetime of significant contributions to a growing specialty of hospital medicine, and with the prospects of doing more in the future. Please join me in congratulating Dr. Shah for being named Master in Hospital Medicine. Congratulations. SHM is fortunate to have the vision and leadership of our past presidents. You can see our presidents here from 1997 to 2019, and I would like to ask you all to recognize them for their significant contributions to the society. I am grateful for the dedication, support, and counsel of the SHM Board of Directors 2018-2019. I want to thank each and every one of you for your hard work and dedication to the society. Chris Frost, President-elect. Ron Greeno, immediate past President. Danielle Schur, Treasurer. Tracy Carden, Secretary. Steve Deitzelweig. Howard Epstein. Chris Ream. Brad Sharp. Jerome C., Rachel Thompson, Pat Torkson. I'd like you all to acknowledge the 2018-2019 SHM Board of Directors. We are fortunate to have 4 new board members join us this year, and I would like to acknowledge them. Flora Kisulit, Bryce Gartland, Mark Shen, and Chad Whelan. We welcome you to the board. I also would like to let you all know about our new board officers. Yesterday, the board of directors selected Daniel Schur as president-elect, Tracy Cardin as treasurer, and Rachel Thompson as secretary. Thank you all. I would like to take a moment to say goodbye and thank you to our board members who will be leaving the board. Please hold your applause until all the outgoing board members have come to the stage. I'd like to ask Howard Epstein to join us up here on stage. Thank you, Howard. Thank you. Howard is the Senior Vice President and Chief Medical Officer of health insurance company Preferred One. He's an adjunct assistant professor of medicine at University of Minnesota. Previously, he was a practicing hospitalist and on faculty of Regions Hospital in St. Paul, Minnesota. He served as SHM's chair of the ethics committee in the past, and on SHM's board of director for the past 6 years, also serving as secretary of the board. I would next like to ask Brad Sharp to join us on stage. Brad Sharp is the professor of clinical medicine at University of California, San Francisco, and the chief of the Division of Hospital Medicine at UCSF Health. He previously served as the associate program director for UCSF Internal Medicine residency. He has served on numerous SHM committees and projects and has been a course director for Academic Hospitalist Academy since its inception. For the past 6 years, he has served on the SHM board of directors. I would like to ask Pat Torkson to join us on the board. I am going to move forward with Pat's introduction. Pat is the Chief Medical Officer at St. Tammany Parish Hospital in Covington, Louisiana. He's served as the chair of SHM's Performance, Measurement, and Review Committee for the past 6 years and has been serving on the SHM's Board of Directors. Please join me in thanking our outgoing SHM board members. Thank you.
If I could have the opportunity to be the one that says a couple remarks about my good friend Ron Greeno, who's leaving the board after being our immediate past president. And I first met Ron Greeno 20 years ago at my first SHM meeting. At that time, he was the founder of a little company called Cogent Healthcare that was one of the emerging hospitalist companies in a very young field. And Ron's had the distinction throughout his career of having worked for just about everybody in hospital medicine. Cogent was acquired by Sound, and he worked there, and then he moved on to IPC, and eventually to Team Health. And now we're fortunate that Ron is working for SHM as our senior policy advisor in Washington. Ron's had a long career at SHM as the chairman of our public policy committee. He is a fierce advocate for hospital medicine and for the future of healthcare in the halls of Washington. He's a good, solid Nebraska man, and he brings his vigor and his charm to play. So I want to call Ron to the stage, and let me say goodbye to him. Now, something that wasn't on the script, when you're very close friends with somebody, you know stuff that other people don't know. And Ron still holds the high school record for the 1 mile in Nebraska. And so I thought what he'd really need as he retires from SHM is a Nebraska shirt.
Go Big Red.
So join me one final time in thanking Ron for everything that he has done and will do for SHM.
It has been an absolute privilege and honor to serve as the president of SHM over the past year. And what a dynamic year in healthcare. As we race towards affordability and value, we saw some unlikely partners like Amazon, Berkshire Hathaway, and JPMorgan Chase launching a new healthcare venture. We saw some startups that moved towards healthcare like Uber Health, and we saw increasing numbers of mergers and acquisitions like CVS Aetna creating a $69 billion healthcare giant. So what does all of this mean to us, hospitalists, and our specialty of hospital medicine? Change happens, whether we like it or not. We cannot avoid it, and we cannot slow it down. It is not change, but our response to it that defines us and our future. And we own that response. This can be unsettling as it brings uncertainty and risk into our day-to-day life. But we've all experienced this in our personal and professional lives. The theme of adapting to change resonates quite a bit with me in my personal journey of getting here. Like some of you, my family and I immigrated to the US. Just before immigrating, for a period of several months, my city was subject to regular air raids where military planes dropped several bombs throughout the city on a daily basis. So several times a day, as an 11-year-old, I found myself crouching under a table, looking at my 6-year-old sister and my parents, wondering if we would make it through the next moments. My parents, who were British-educated engineers, had the foresight to immigrate to the US. I cannot fathom the tremendous risk that they took to step away from the security of their family, great home and jobs, to move the family to a new land. But here's the great thing about change. Change has the power to hold significant opportunity and potential, the potential for a better future. An insightful person was once quoted saying, "It's not the strongest of the species that survive, nor the most intelligent, but the ones who are most adaptable to change." While there's debate on the internet about who originally said this, there's absolutely no debate that the theme in life and in healthcare is adaptability in the face of constant change. So how do we succeed? In order to succeed, we have to relentlessly survey the environment and understand the national trends and what ultimately matters to our patients. I feel quite fortunate that over the past several years, I've had a chance to visit with a number of you in your hometowns and your home institutions. From Seattle to Lubbock to New York, all across the nation, 4 major themes have emerged, and I wanted to share those with you all. The first one is that there's a new setting of care. The care of the patients are moving from the hospital to the ambulatory setting. Some of the surgeries that we used to do in the main OR are now being done in ambulatory surgery centers. Antibiotics are being infused via IVs at patients' homes. And some of the bread and butter cases that I used to see a decade ago as a hospitalist, like cellulitis and pneumonia, aren't being treated in the hospitals. They're being treated at home. Don't get me wrong, hospitals will always be there. We will always have traumas and acutely ill patients that will need centralized hospital-based care. But make no mistake, care is actively moving from the hospital to the ambulatory side. Second, there's a new priority in healthcare. There is a purposeful focus on health and well-being. There's a transition as a society on focusing on the sick to prevention of disease. We're still far from that vision, but we're working actively towards that. How can we prevent chronic illness once it has occurred, or how could we limit its progression? This is a very new focus for us in healthcare. Third, there's a new system of care. There's a transition from hospital-based teams to the patient's care team. The patient's care team now involves a number of staff and providers that are on the ambulatory side, primary care doctors, pharmacists, case managers, all of whom provide support for the patient towards the entire continuum of their care. Lastly, there's a new focus on patient-centered care. And this isn't about HCAHPS scores. That's just a metric. It's a focus about how we can be everywhere the patient is at any time that the patient needs us. So how do we respond to these trends? Well, last year, the SHM Board of Directors had several strategic meetings discussing the role and future of hospitalist and hospital medicine in population health management and value-based care. And several things emerged out of that. First, we have to define ourselves not by the four walls of the hospital, but by the values and competencies that we bring to healthcare in caring for acutely ill patients, wherever they are. They may be in the hospital, maybe in a skilled nursing facility, or they may be in their own bed at home. Or that entire encounter could be virtual. We have to be able to meet the patient where they are for their acute care needs. We need to leverage the acute care episode to ensure that the patient is connected to a larger system of care, one that can ensure after the acute period we focus on wellness and prevention, that we engage the patient through programs such as telehealth, and that they are supported by a multidisciplinary team of providers and staff on not just the inpatient side, but also the ambulatory side. While change is a necessary ingredient in life, I have been personally blessed by a number of constants in my life that have given me support and strength to move forward, and I just wanted to take a moment to thank them. I want to thank the SHM Board of Directors for an incredibly productive year as we led discussions in population health management and what that means to our future. A special thanks to my officers, Danielle Schur, who served as treasurer, Tracy Cardin, who served as secretary, and Chris Frost as president-elect. I am absolutely thrilled to pass the baton to Chris, whose thoughtful and diligent approach to hospital medicine and hospitalists will continue to advance our specialty. A constant at SHM for the past 20 years has been our CEO, Larry Wellickson, who has led us fearlessly, setting a vision and rapid pace for the establishment and growth of hospital medicine. I would also like to thank my family, my parents who, despite their individual and collective struggles, embraced change wholeheartedly, taking a big risk and leaving a life they knew behind for the potential and opportunity for a better life for me and my sister. My husband, who's been a true partner in my journey in life, and his support has meant the world to me. And my two girls, who challenge me each and every day. I could almost put a period after that, but I'm gonna go on, who challenge me each and every day to be a better person and inspire me to make a positive impact in the world. And mostly, they laugh out loud with me through joyful and challenging times in life. So remember, change happens whether we like it or not. We cannot avoid it or slow it down. It is not change, but our response to it that defines us and our future. And we own that response. So whether you're a frontline hospitalist holding a patient's hand during the most vulnerable moments of their life, or a hospital executive seeking new growth opportunities, or on the health plan side creating innovative value-based programs, or the policy side leading the way to affordability, run towards change and be a force of positive change. Thank you so much. I would now like to introduce Chris Frost, our president-elect. He is the National Medical Director of Hospital-Based Services for LifePoint Health and a member of SHM Board of Directors since 2015. He was the treasurer before becoming our president-elect. Please join me in welcoming Chris to the stage.
Good morning. Well, thank you, Naseem. And allow me to add my welcome to HM19. We are thrilled and excited to have you here and eager to delve into this year's annual meeting. I am truly honored and humbled to serve as the incoming president of SHM. My comments will be brief. Why? Because Larry said, Chris, your comments will be brief. I'm going to introduce a new word into some of our vocabularies. The word is multifarious. It is an adjective and it means many and various types. I don't know the origin of the word. However, it's not the origin of the word I'm here to discuss. I'm here to discuss how it relates to us and our specialty, hospital medicine, and how it's especially germane within the context of time we're in right at this given moment. It's a time characterized by rapid change. Just heard a little bit about that from Naseem. And that change has and will continue to influence us as hospitalists. It's not the change that defines us, it's how we respond to that. We will not just react to, but actually help author aspects of this change. The change I speak of is multifaceted. Just a few examples include adjustments, changes in the reimbursement model as we continue to pivot from fee-for-service to value-based purchasing and risk-based model. Changes in healthcare relationships, not unlike the ones Naseem just framed up, and what we're going to see is that the types of relationships forming. Another example, such as Walmart acquiring Humana, what we're witnessing is a hybrid species that's new to the environment. We're also seeing changes in our understanding of disease processes and their linkages to social determinants of health. Many of you will recall Karen DeSalvo speaking on this very topic at an annual meeting just a couple years ago. And this is just a sampling, a few examples of the changes that are defining the dynamic and shifting environment we find ourselves in today. As the SHM Board of Directors, we spent a lot of time discussing the selective pressures driving these changes and the innovative and diverse ways many of you are influencing our specialty as you adapt to these changes. If you peruse the conference schedule, you see evidence of how our facility is facilitating a dialogue, and in many respects, not just a dialogue, but formulating an action plan around these changes. Just a few examples in terms of the presentations, discussions, works groups that you'll be exposed to over the next few days include hospitals' involvement with population health, leveraging technology through telehealth to expand our reach and enhance our efficiencies, several sessions around caring for diverse populations and building out diverse teams to provide this care. A few examples of this include caring for vulnerable patients, understanding and addressing the care needs of LGBTQ and transgender patients, caring for patients when caregivers themselves are confronted with discrimination from the very patients or family members the care is being provided to. There will be discussions around caring for ourselves and our teams in order to provide exceptional care for our patients. It's not just a plenary session tomorrow. There's multiple work groups and sessions interspersed throughout the conference on this topic. These are all examples of diverse teams taking care of diverse populations. There isn't a single presentation with length of stay in the title. It's not that LOS isn't important. OMG, that's not what I'm saying. Instead, I'm recognizing our specialty has always had an Alps upon Alps appear approach when we're confronted by change and challenge. When we summit one mountain of our own professional Alps and we see another on the horizon, we say, let's climb that one. Let's go there. Thank you. This is exciting and inspires us, your SHM Board of Directors. With that said, your appetite to confront the challenge, to embrace and adopt change, doesn't surprise us at all. Hospitalists are known for challenging the status quo and innovating in order to develop a better path, a better system, a better process of care. I don't say this with hubris. I say this with humility. The humility is because we're not done yet. As we are presented with the changes in the healthcare environment, we will need to adopt and change our system and processes again and again and again. It'll be an iterative model. How we do this is still evolving, and one thing I am confident of is it will require us as hospitalists to expand our view, if you will, expand our field of vision. This will include exploring many and a variety, that is multifarious, duties and roles within our hospital and health systems, some inside the four walls of the hospital and some outside. It'll also require us to establish and foster many and different types of relationships, and that'll be with an increasingly broad range and diverse group of stakeholders, again, both inside and outside the hospital. We at SHM have always had a big tent philosophy. I really believe our tent is about to get even bigger. The response to change will at times push us outside our comfort zones. That's okay. That's growth. So thank you again. Thank you for the privilege to serve as SHM President, and I encourage you to reflect on this expanded field of vision and participate in the ensuing dialogue over the next 3 days at the conference and beyond. It promises to be an exciting time. Thank you.
I am thrilled to introduce our keynote speaker, Dr. Mark Harrison. Before I jump into the introduction, I wanted to give you a sense of the format for this. Dr. Harrison is going to give us a keynote address, and then we're going to take about half the time and get to do some Q&A. Dr. Mark Harrison is the president and CEO of Intermountain Healthcare. He's a pediatric critical care physician with a proven track record as a top operations executive on a global scale. He's national and international thought leader on healthcare transformation and innovation, ranking second among modern healthcare's most influential physician executives and leaders, and tied for second on its list of 100 most influential people in healthcare in 2018. Dr. Harrison is leading Intermountain's 38,000 employees, who are all called caregivers, to embrace the bold new approach to improve health, redefine value-based care, and serve people in a new way. Prior to his current role, he served as the CEO of Cleveland Clinic Abu Dhabi, Chief of International Business Development at Cleveland Clinic, and Chief Medical Operations Officer at Cleveland Clinic. Dr. Harrison received his undergraduate degree from Haverford College and his medical degree from Dartmouth Medical College. He completed a pediatric residency and a pediatric critical care fellowship at Intermountain's Primary Children's Hospital. He also received a Master of Medical Management at Carnegie Mellon University. Dr. Harrison is also an All-American triathlete and represented the United States at the 2014 World Championships. Please join me in welcoming Dr. Mark Harrison.
Wow, that was a really nice introduction. Our oldest kid, Alex, is actually in the audience today. Are you out there, Alex, or did you sleep in? There he is. So Alex is a medical student at Ohio State, and this is his first professional meeting and his first opportunity to present. So will you tell Mom I got a really nice introduction here, Alex? Okay. She won't believe it, but that would be really great. So I'm really glad to be here. I'm glad that we're going to make this an interactive session. I'll tell you that Nasim really teed things up. with her emphasis on the fact that change is so important. And I will tell you one thing, that if there is a single core competency that each and every one of you need, it's actually the ability to lead change in a positive fashion. Because our profession, our industry, is in an absolute inflection point. And the other thing I'd want you to know is that we still, despite that change, are privileged to do things that other people wish they could do, which is affect people at the most vulnerable points in their life. And we get to serve others. And people watch us every day as we do that. And each and every one of us is a leader, and how you manage yourself through this changing environment is sending clues and cues to your entire organizations. And that's actually both a privilege and an enormous responsibility. I will forego the usual president and CEO slide that shows you our empire, and I'll just quickly give you a very short snapshot of who we are. I'll do it verbally so that you can understand a little bit about Intermountain. So we're based in Salt Lake City, Utah. In 1975, the Church of Jesus Christ of Latter-day Saints gave 14 hospitals to the community in trust. Now, they were also very smart. They were very generous, but they were smart. They all needed to be recapitalized. So that was actually like perfect timing, right? They gave this charitable asset to the community with a single admonition, and that was, be a model healthcare system. That was in 1975. And have care be extraordinary, accessible, and affordable for all people. So this is actually a huge advantage that we have. We have crystal clear understanding of why we exist. So we are based in Salt Lake City. We have now 23 bricks and mortar hospitals, and we started a virtual hospital about a year ago. It's now the largest virtual hospital in the United States. We serve either physically or virtually in 5 additional Western states, and we also work in Alaska in the same manner. We are privileged to touch about half of Utahns every year and about 75% over the course of a lifetime. We have got a health plan called Select Health that has just over 900,000 members in it, and that functions now in Nevada, Utah, and Idaho. We are an integrated system. We talk about being one Intermountain, and I've brought a leadership team together that everyone sits around the table together. We have got the health plan represented, the doctors represented, the hospitals represented, and what we understand is that there is only one bottom line that counts, above and beyond service, which is the most important thing, and we make compromises together in the effort of achieving those goals. We are a transformed healthcare system, and boy, has it been hard getting there. But we have also made the decision that we would do this from our front foot. We would do it when we were at our most economically and clinically strong, because this transformation towards value is really, really difficult. But I will ask you to think for a second about all those patients who you see who you really shouldn't have seen in the first place. So how many diabetics have you seen who, if they had actually just been able to afford their insulin, if they had had their testing strips, if they had had a good primary care physician, they would have never ended up on your service? How many asthmatics do you see who know they have a dust mite allergy but don't have the money to go ahead and have their houses appropriately cleaned? We know that in the United States of America, we know that about 1/3 of the health care that we deliver is actually wasted or redundant, right? So by doing non-evidence-based, non-standardized care, we waste every day. And that's just under $1 trillion a year we think get wasted. And that's CAR T-cell therapy for everybody, right? There's plenty of money in American healthcare. It's just being misspent. And that doesn't even address the social determinants of health, which we'll talk about in a little bit. So we are at an inflection point in where healthcare is going. And the question is, are you, as leaders and as clinicians, prepared to disrupt yourselves in the interest of doing the right thing for the people you serve? So we actually asked ourselves really hard questions. Are we going to just kick the can down the road as a very successful healthcare system in a largely volume-driven environment and continue doing that for as long as we can? Or as one CEO from Colorado said to me, she said, I'm going to ride this pony until it drops. Right? We didn't think that was the right thing to do. And I think you probably don't think it's the right thing to do either. But it's going to require humility and risk-taking and a desire to truly serve others if we're going to change the paradigm for how healthcare is delivered. So let me tell you some facts as I understand them. And I think these are real facts. These are not fake facts as far as I can tell. Healthcare is not becoming unaffordable. It is unaffordable. The number one thing that Americans worried about when they left the midterm elections is the cost of healthcare. The number one cause of bankruptcy in the United States is healthcare. The average American can't afford a $400 unexpected expense, and that includes healthcare costs. So there may be a branding opportunity for you all. So the ratings agencies, so the credit agencies for hospitals and for businesses, have given a negative outlook to all of healthcare, right? Especially not-for-profit healthcare. And I bet a lot of you work for not-for-profits. And the reason they've given a negative outlook is margins are dropping. So I hate to talk about money, but it is actually important when one thinks about performing our mission. So the average margin for hospitals in the United States is down to 1.9%. That's actually less than a grocery store. And you know how grocery stores are really sensitive to small changes in the economy. Change in payer mix, shift away from the hospital, which you heard about from Nassim. So I think these numbers are accurate. So 15 years ago, 1.2 million hospital beds in the United States. Now about 800,000 hospital beds in the United States. 15 years ago, average occupancy of 85%. Now average occupancy of 60%, right? 20% of hospitals in the United States are considered either distressed or in danger of closing. You heard about some of the M&A activity. I actually think it's great. It's going to be completely disruptive, but you're seeing movement now because we are wasteful. We're too expensive. We're not consumer-centric. We provide uneven quality to people. And the response from the market, which is very powerful and very American, is that we're going to go ahead and fix this. And engineers from Google and Amazon and Microsoft, who are terrific, are going to work to change models. And if we're not careful, our hospitals and our healthcare systems can become Blockbuster. Anybody been to Blockbuster recently? Right. I didn't think so. They were very happy, right? And we used to pick up a VCR movie every Friday night on the way home from work for pizza night with the kids. And now things get streamed. Even last year, ESPN laid off about half of their staff. Why did they do that? They laid them off because they misjudged the streaming environment. We need to be on our front foot. Consumers demand transparency. Can anybody understand their hospital bills? Right? How can we admit people for routine things and say, this is going to be very difficult, this may be painful, and I can't tell you at all what it's going to cost, even though I know you're responsible for a lot of this from your own pocket? That's just wrong. And we are trying to change that, and we're very imperfect at that, but this is a demand from consumers. We talked a little bit about new entrants in the market. On the M&A front, I think there's actually real value to a lot of M&A. That said, a lot of the massive hospital M&A that we've seen, as far as I can tell, actually adds no real value when it comes to the patient standpoint. These are roll-ups that I think probably benefit people like me, who are CEOs. Unlike me, I suspect many of them are compensated in part on top-line revenue. And I think they probably drive some irrationality. I think what you're going to see is people are trying to make sense out of a system. So I had opportunity last night to have dinner with some of the Intermountain hospitalists who are here, and Dr. Linda Venner, who is our lead hospitalist, she described to me the hard work they're doing to harmonize all of hospital medicine across our system, which has a footprint about the size of Italy, and how they're using telehealth and distance meetings and face-to-face meetings to make sure that people get harmonious care. That's the kind of systemization that actually really drives value for patients. And then finally, I quickly want to mention the rural health crisis. So we are privileged to serve a vast area without a huge number of people in it. And some of our hospitals are frontier hospitals, and they're more than 100 miles away from the next town. Rural health care is really in crisis. We've had about one rural hospital closure per month over the last 10 years. So extraordinary. And there are about 170 rural counties in the United States that have lost obstetric coverage in the last couple of years. And people are experiencing real distress. And I think if we can run our businesses in a value-based and population health-based way, we can actually turn that around. And maybe Nassim and I can talk about that in the future. When Karen DeSalvo came to talk to you, she may have actually showed you this slide or a version of it. And the way I interpret this is we're spending a ton of money in the United States, more than any other developed country in the world, on all the wrong things. So, and this is coming from an intensivist. So what we know is that about 10% of a person's health comes from hospitals and clinics. But we spend 90% of our money on that 10%. So that diabetic, that asthmatic, if we spent our money in the right way, they wouldn't need our help, at least not in that fashion. There's a very compelling slide or graph that shows that if we actually add up money spent on social services with money spent on health care, the US is actually at about the same level as the other developed countries in the world. But they're achieving health outcomes that are far superior to ours. So what we need to do is flip that spending, and we need to get into the business of keeping people well. Now at Intermountain, we're very fortunate, and we've worked very hard to deliver real population-based health. So 41% of our business is now in full risk arrangements. So we're prepaid to keep people well. So now it makes sense to address people's housing, address people's transportation, address people's food security. This is what is going to save American healthcare. Every system is perfectly designed to get the results it gets. And what is America's healthcare system largely designed around? Heads in beds, driving volume, and doing more for people than they actually need to have done. And a wave of change is coming like you can't believe. So estimates of up to half of knee arthroscopies don't need to be done. The evidence isn't there. How many people get joint replacements that actually could get by with physical therapy? The single greatest predictor of getting spine surgery is the number of spine surgeons in your community. That's actually true. That's like old Dartmouth Health Atlas information, right? this is the perversion of American healthcare. Now, if you're really sick, if you're really messed up, if you're really hurt, nobody does rescue care better than United States healthcare. Nobody does better. But if you actually want to keep a population well, we've got a lot to learn from a lot of people. So what has our response been to this, this piece of information, in addition to really driving towards risk-based contracts and actually trying to understand and reorganizing our entire operation around keeping people well? We recognize that if we're going to be really good at this, we're going to have to learn a lot. And so we've identified 2 geographic areas, one in northern Utah near a town called Ogden that has a lot of urban problems, and one in southwest Utah near a town called St. George that has a lot of rural problems. And in each of these areas, we have Medicaid populations within the zip codes in each of these areas, about 4,000 members. And we're both the payer and provider. We are completely at risk for taking care of these folks. We are investing $2 million per year times 3 years in each of these geographic areas. And we're partnering with the communities to understand what levers we need to pull in order to keep populations well, and what interventions are going to happen. So this is not some do-gooder charity project. This is real R&D into what population health needs to look like for the future. We're doing this on our front foot when we're economically and clinically strong. My concern for US healthcare is that we're waiting. People keep kicking the can down the road. They keep driving volume, and they keep getting economically weaker. And while they're doing that, their ability to actually make the investments that are going to be necessary in doing the right thing is going to diminish. And I think that's a crisis that's coming. So my plea to all of you as leaders and as clinicians is to push hard to start doing the right thing as quick as possible. So this is what we need to do: lower the cost of care. Boy, so there's a big health system in the Northeast that's very well recognized and is having some economic problems. And at a meeting I was at, one of their board members said to me, "Mark, how do we get our system to actually make the pivot towards value and towards population health?" And I paused for a minute and I said, "Aren't you the board member, right? Isn't that governance's responsibility to actually ask to do the right thing?" And we as leaders and as management are responsible to our governance as well, because they're supposed to represent the communities that we're serving. But I think we as leaders and as clinicians, we can actually ask that question. We can ask our boards, are you willing to forego some revenue so that we can put money back in people's pockets? So we have restructured our organization to take cost out. So over the last couple of years, we've taken about $250 million out of our run rate. Why have we done that? Because despite the fact that Utah has the second or third lowest cost per capita of all states in the United States in terms of health care, we have the second highest out-of-pocket because of the predominance of high deductible plans. So in order to be competitive, but also in order to be humane, we are making the shift towards outpatient. We are lowering the cost of shoppable procedures. And probably most importantly, we're lowering insurance premiums. So last year on the individual exchange, and we've got about 250,000 human beings who we care for on the individual exchange, our average premiums we dropped by 3%. Boy, that takes a lot of discipline. But if people can't afford what you're doing for them, it's incumbent on us, before we're disrupted from the outside, to do the right thing for these people. I'm sick of pilots, right? One of my friends calls it pilotitis. So how many of you guys, I'm not going to ask you to raise your hands because I suspect, are doing pilots in population health? It's baloney, right? It's ridiculous because you know what to do and your organizations know what to do, but they're addicted to fee-for-service revenue. And they're foregoing the pain of making the switch to doing the right thing because they don't have the courage to actually make the hard changes. And that's wrong. The right thing to do is to go back to why we all went into this business in the first place, which is the privilege of serving others. But it doesn't matter how technically good you are if people can't afford what you're doing. And it doesn't matter how technically good you are if the things you're doing to them they don't actually need in the first place. So modernize at scale, get after it, and do it as soon as possible while you're as economically strong as you can. And then move upstream. Somebody, I think it's Nassim, you know David Feinberg well, right? Who's now the CEO of Google Health. So David was the CEO at Geisinger. He's a child psychiatrist. And he likes to talk about, let's stop taking care of the kids with rat bites. Let's go into the house and kill the rats. And this is what we need to do. This is actually how we change healthcare in the United States. So there's going to be a move upstream in terms of how we care for patients, but we also need to address those social determinants as well. So one of the great perversions of American healthcare is what's gone on in the pharma industry, specifically in generic space. And in my first week as CEO at Intermountain, a guy named Dan Liljenquist, who's now our Chief Strategy Officer, Dan came to me and he said, I've got this crazy idea that nobody really wants to hear about, but I think that we can address the generic drug crisis. So I will remind you that the CEO of Mylan personally put $50 million in her pocket with the whole EpiPen debacle, right? $50 million. I will tell you that another CEO was quoted in the newspaper as saying he had a moral obligation to his shareholders to get every last penny out of his generic drugs possible, regardless of whether people could or not afford them, right? Totally wrong. So I'm proud that Intermountain, along with Mayo and SSM and Trinity and Providence and a number of other systems, have come together to create a not-for-profit, utility-style model for generic drugs. First, yay, right? First drug will be out next quarter. I know what it is. I can't tell you, and no matter how many drinks you buy me tonight. But it's coming. This is really exciting. More than 1,000 US hospitals have signed on, and we collectively are going to change the world on this front. There's an inpatient division now, an outpatient division is getting started, and there is going to be some radical philanthropy that is going to happen that is going to allow us to take on some really extraordinary and obscene challenges in the generic drug space. So this is the kind of thing that we can do together if we have the courage to take a little bit of risk and think outside the box. So some of you may think like that Utah is completely idyllic and we don't have any problems like the rest of the world has, but that's actually completely not true. We have all the same problems. I would say our advantage is we're small enough that we actually might be able to solve them. So Utah has ranked in the top 6 or 7 in terms of deaths from opioid misuse for the last decade. It's terrible. So the opioid crisis is alive and well in Utah. Intermountain, given our size and scope, felt a moral obligation and a clinical obligation to try and fix this. Our clinicians, this is clinician-driven, have come together and last year dropped opioid prescription by about 30%. They took 3.8 million pills out of our communities in the last year, and we are one of 5 states in the United States that showed a decrease in opioid deaths. So dropped by 20%. That's a lot of families that get to keep their loved one, right? That's really important stuff. this is what you can do if you actually are willing to do hard things and you let your clinicians provide you with guidance around how to care for patients. So you guys have a unique and critical intersection, and I think one of your branding opportunities, and I think Chris was alluding to it, is I think if I were you, I wouldn't call yourself the Society for Hospital Medicine for very much longer. What Linda shared with me last night, Dr. Venner, is she said, our core competency is taking care of very sick patients with multi-organ dysfunction that aren't quite sick enough to be in the ICU. She didn't say anything about where that locus needed to be. So it really strikes me that your specialty is rapidly becoming acute care medicine, regardless. So you're going to be relevant in the hospital, you're going to be relevant via tele, you're going to be providing consultative services across distance to colleagues who are in too small a place to have their own hospitalist programs. You're going to be taking care of patients at home. You're in the absolute perfect place to keep patients in the least restrictive, least expensive environment where they can receive superb care. As they say in Hamilton, you're in the room where it happens, right? So I think this is an incredibly exciting specialty that you have, although I think the name may become somewhat outmoded in the near future. Your skills are exactly what the world needs, particularly given hospital medicine's history of trying to drive evidence-based and very effective, efficient care. So this is where I think that we need to go. Patients don't really care what their New York State heart failure score is or whatever it's called, right? They don't care. Patients, if you ask them, will say, I want to be able to drive. I want to be able to go to my grandson's soccer game. I want to dance at my daughter's wedding. And I think that if we start asking those questions in a very organized and persistent way and communicate our humanity to people who share their humanity with us, that's where healthcare is going. And that's actually what people are demanding. And that's a good thing. Be intentional and holistic about people's care. And I think we've discussed that enough. But what we've tried to do at Intermountain is we've reorganized ourselves. We recognize that we're fundamentally in two basic different businesses. We're in the keeping people well business. And then, as my dad said, no one gets out alive. So we're also in the taking care of people when they're really sick business. But that tension between those two is worth exploring. And I really see hospitalist medicine on the tipping towards the edge of the keeping people well. That connection back with the community and that return of patients to their primary care physicians in a seamless fashion is something that you all should do really well. And it's really important. And I am proud of our Intermountain hospitalists who achieve readmission rates that are in the top couple percentile in the United States by having a consistent, relentless focus on returning patients back to their home communities and their primary care doctors as quickly and seamlessly as possible. So with those comments being said, I think, Naseem, you're going to come back up here and grill me, right? While she's coming up, I just want to say thank you for the opportunity to be here. And I want to reiterate that I think that you're in exactly the right place and exactly the right specialty to make an enormous difference for our country, which desperately needs an upgrade in terms of how we approach keeping people well and then taking care of people when they're sick in a super efficient as well as humane and innovative fashion. So thank you very much.
Thank you. Thank you so much, Mark. Yeah, let's take a seat. Thank you so much for that thought-provoking conversation. And I think we hear a lot of common themes around the evolving role of health systems and delivery systems. And I think looking at some of the examples that you shared with us with Civica, for example, we see delivery systems getting into lines of business that we didn't used to be in. Right. Talk to us a little bit about the virtual hospital.
So this, like many other things, the initial seeds of it developed from necessity. So across our very large footprint, our clinicians began to support each other via tele. And about 3 or 4 years ago, a decision was made that every single ICU bed would be covered by telehealth. And we discovered something really interesting. In addition to the fact that patients had shorter lengths of stay, lower cost per case, and improved observed to expected mortality, in our small hospitals, the same thing was achieved in our big tertiary and quaternary facilities. So that in really busy ICUs, having somebody keep a set of eyes on the patients who looked like they were doing fine actually ended up making a huge difference. And that rapidly expanded into about 40 specialties that are delivered. So we run everything from antibiotic stewardship virtually, teletrauma evaluation, teleneonatology, and some of the stories are actually really dramatic. So for instance, one of our rural hospitals in central Utah noted that patients who were diagnosed with cancer were choosing to die instead of spending what would have been the rest of their life driving back and forth to the big city to get their chemo. And so now we've got tele-oncology in about 7 or 8 different places. And patients are living, and they're living well. And the really interesting thing is, as we work hard to keep people in the lowest acuity setting, those hospitals actually remain economically vibrant. So one of the solutions to the rural healthcare crisis is actually pushing out teleservices to places that actually benefit the patients and benefit those communities, and foregoing revenue at the big centers. That kind of generosity drives good outcomes for patients and then keeps those rural hospitals economically strong.
It's really interesting. I think it really combines a couple of the themes that you introduced to us, both in terms of really understanding what the patient wants, being able to deliver a holistic level of care for them, but also making it economically feasible and sustainable for the longer term.
It has to be economically feasible and sustainable. Although if you think about it, for our capitated patients, that actually makes economic sense to keep those patients in that other environment. For our non-capitated patients, it actually is a loss for us. We don't worry about that. Yeah. We will find that money in other ways in the interest of doing the right thing. And that's actually kind of what I'm asking for all of your colleagues to do, is to think about how can we actually change the cost of what we deliver so that that $1 trillion that's wasted every year in the United States can be applied to the patients who really need it. Yeah. There's plenty of money.
You know, as we're looking at the evolving role of delivery systems, we have been thinking a lot about what does this mean for us in hospital medicine. And you brought up one example where hospitalists have been and can be instrumental, and that's in the opioid crisis. I was wondering if there are other examples you could share with us about how the Intermountain hospitalists have been leading the charge towards a new way of delivering care.
Well, I think they are in a couple of fashions. So first of all, this radical idea that regardless of where in our system you receive care, you're going to get the same safety, quality, and patient experience. I would bet that there are a lot of systems represented out here in the room, but each of those hospitals represents an island of how hospitalist practice actually works. So I think that's been fantastic what the team has done. I think they've incorporated APCs really thoroughly into their work, and that gets better and better year by year. I think the team-based care they're doing and the dyad rounding, which I know is something that hospitalists have aspired to for a long time, but don't always consistently execute against. I think they're doing a really good job with. And I think it's this tie back to the community to make sure that when somebody leaves, they are really ticked and tied so that despite our very short lengths of stay, our low readmission rates are reflective, I think, of the great work of the hospitalists.
That's really great. You know, one of the things that we've always prided ourselves in hospital medicine is our team-based approach to care. I think from our inception, the way we were integrated into hospitals, the multidisciplinary nature, how we work with other providers, but also staff, is one of the major values that we bring forth. I know earlier you were mentioning that you have a number of huddles to help communication throughout the entire system. Could you tell us a little bit about that?
So thanks. When I got to Intermountain, I found in about a quarter of the enterprise, there was a really effective continuous improvement process that was in place. And with tiered huddles that happened every day, starting at the front line and ending at the leadership of that part of the organization. But we hadn't adopted it thoroughly across the system, and now we have. So every morning, so in a couple of hours, it'll be 10 a.m. In the Intermountain West. At 10 a.m., my team will participate in a huddle that reflects the safety, quality, patient experience, access, and stewardship of the entire system. So every major safety event, every significant IT downtime, et cetera, will make it to the executive team in a holistic fashion. But in order to do that, 2,500 huddles will have occurred before then. And it happens very systematically, and these are very quick, they're 15 minutes. But it's allowed us to be able to, even in the midst of a massive transformation, to achieve the best safety, the best quality, the best patient experience, and the best financial performance the system's ever had, because it aligns people from top to bottom of the organization so that they need to know exactly what they need to do in order to be successful in our, for the patients most importantly, but for the system as a whole.
It's really great. You know, I think that's a best practice. I'm going to take that back and look at how we can implement that. And I think that increased communication at the end of the day helps move us upstream from where the problems can occur and helps make sure that we're on the same page and communicating to be able to get there. You know, we talked about the direction that we're going in terms of delivery systems, in terms of what hospitalists can do. If we had a crystal ball and we could look in the crystal ball and 10 years down the line, we failed. We did not make healthcare more affordable. We are not more patient-centered and holistic. What would you say, kind of sitting here today, are the high-risk points that would prevent us from succeeding?
I think the greatest risk is in inaction. It's lack of courage. It's waiting until legislation tells us what to do. I think that's what worries me a lot. I'm actually extremely concerned about a large number of the academic medical centers in the United States, and not because they don't provide very good care, but very few of them have actually made a meaningful pivot towards value. And if you look at any one of them, and you look carefully at the patients who are cared for in those settings, the vast majority of those patients could receive the same safety quality experience or better in a much less expensive environment. And the way disruption works is new players will enter and they will chip away at the easy stuff. And they'll siphon that away, and then those centers are only going to be left with really sick, really complicated patients. And if you're in a fee-for-service environment, which these academic medical centers almost are in completely, they become that margin of 2%, poof, gone, done. And then they've tipped over the edge, and they're economically distressed, and they're Now, some of them have such huge endowments, they'll be okay, but a lot of them are just going to be dead. And so where do we get our innovation from? Where do we get our great trainees from? And I worry a lot about that. And remember I said 1 out of every 5 hospitals is distressed or in danger of closing. We could also see relative crises in lots of our communities in terms of unavailability of services or reduced availability of services. So we're all smart enough to make the changes that are necessary. The question is, are we brave enough?
I think that's a really great point, and I think having had my entire career in extremely competitive market environments and market regions, we're already seeing some of what you're talking about, where again, cases that had larger margins that were simpler are moving out of the academic medical center. And again, what's remaining isn't really something that's sustainable in the longer term. I think academics is in large part trying to look at how do we redefine ourselves as we're moving forward. And again, to your point, it's going to take a lot of courage and us doing things differently to actually get there.
And the plea also is, let's train our trainees in this new way of thinking. You know, it's interesting when you go on rounds in academic medical, my wife and I trained in the early 90s, it looks the same. People pre-round the same way, they present the same way, a little bit more team-based, which is great, but not fundamentally different. And I think it's going to require a fundamentally different approach. And our patients actually kind of deserve it.
You know, you're at Intermountain Healthcare leading one of the most innovative health systems forward, and I'm sure you're constantly looking at what are the new and upcoming trends in healthcare. I was curious if you could share with us what are some trends and things that you're looking at as you look out in terms of market disruptors that could really change how we do things.
We talked about a couple of them, so I think hospital at home, big. Anybody out here know Babylon? Ever heard of it? So Babylon's a symptom checker, AI-based. It's not perfect, but it's actually getting a lot better. So Babylon worked with 40,000 NHS patients in the UK, and they held their doctors harmless economically about whether they actually saw the patients or not. And what they found is that by giving patients access to the symptom checker, 40% reduction in primary care visits. And the health status of the population improved. So that's like, you think that's anybody out there in a fee-for-service oriented academic health system, that's death, like right there, right? For somebody who's in a population health environment, that's fabulous, right? So people stay right at home, they can interact over their phone. So that's the kind of thing that's coming, that's a disruptor. And then the other one is, for the young people out there, especially, they are comparing their healthcare experience to their online experience with social media, with banking, with food delivery, with personal services like getting your hair cut. I mean, everyone here can get their hair cut, make that appointment on their phone now, right? How easy is it in each of your places to do the same for a doctor's visit? Not very easy for most folks. So that kind of level setting of expectations is happening, and it's happening really fast.
It's really interesting when you look at the movement from, you know, when I used to get airline tickets 2 decades ago, and you had to call a travel agent, and they used to read you the times that the flight was, and you'd go and check a calendar, a call back, and again, now you get on your phone and you pick exactly what you want down to the seat that you want. You look at grocery stores where instead of standing in a long line, you're now going and you're checking out your own groceries. You know, I think some of this stuff, if someone would have told us 20 years ago this is what we would be doing, would think that's
they would have thought we were crazy, but this is just the fact of life. And so I think probably the thing that I want to emphasize, and I don't want this to be scary, is the pace of change is accelerating, not leveling out or decelerating. But with that comes enormous opportunity for affordability for patients and for better quality and for a healthcare system that actually keeps people well. And I think that's what keeps us going every day.
It's really great. So I'm going to shift gears a little bit and focus on provider wellness. It's a topic that's very much top of mind for us in hospital medicine. We have Tate Shanafelt from Stanford who's going to come and speak to us tomorrow. You have, I am sure, what is an extremely stressful job, and you have balanced that with wellness and well-being. Can you talk to us a little bit about your secret to that and how you manage all of that?
So I will do that, but before I do that, I want to give a shout out to our hospitalists who have, we have problems with burnout and stress at Intermountain, big problems. The hospitalist group in particular has done extraordinarily well with very high engagement and very low burnout rates. And at dinner last night, what they were sharing with me is they think the reason for that is they're part of the solution. They're actively engaged in making things better for themselves, their patients, and their colleagues. And that sense of internal locus of control, they actually credit to their high satisfaction and low burnout rates. Personally, I actually don't think my job's all that stressful. I've got a great job. And the reason it works really well is I've got a very carefully selected team. I'm obsessed with talent. And I set really clear goals, and then I let people run really hard. And you know, for all of you who teach clinically, it's much scarier to watch somebody do a procedure than it is to watch somebody do a business deal, right? So,
Very true.
So we can almost always walk back a business thing, but if you hurt or kill a patient, you can't walk that back. And so I kind of keep that perspective, and I don't have work-life balance, I have work-life integration. Some days are all work, some days are all play. Most days have elements of both, and it works for us.
That's really great. So make sure that you've got the right people around you, make sure that you have clear goals and accountability, and be, again, that force for positive change to be able to re-energize yourself and give you that sense of focus.
Yes, and I would say if you know that somebody's wrong, not like a bad person, but wrong, get them out as quick as possible. You don't do anybody any favors, least of all that person who's not doing a good job. So I think identifying talent and get them in place and then give them all the support in the world that you can, that really is a key. But letting people sort of be in place but ineffectual sends terrible messages throughout the entire organization because people know they're not very good. And it's unfair to them, and it's unfair to the people who are really doing effective work around them. So I think being obsessed with talent and being obsessed with facilitating growth of the people around you is actually the key to success.
It's really great. Well, Mark, we have immensely enjoyed having you here.
Thank you.
Thank you so much for spending time with us this morning, and thank you for the keynote address.
It's a pleasure. Thank you very much.
Thank you so much. Thank you. Once you go, I'm gonna. If you haven't had a chance, please check out HM19 at Hand app for access to schedules, session presentations, and RIV abstracts. You can look for details on the signs that are out in the hall. And please stop by the exhibit hall. It's open until 10:30, and enjoy SHM Quick Talk starting at 9:45 in the exhibit hall. Thank you all.